Hello, this is Sindhu Shamasunder, epidemiologist with the North Carolina Department of Health and Human Services. This slide set was created to provide basic data trends and public health surveillance around the drug overdose epidemic. They are meant to offer a basic state-level background on drug overdose. If you'd like a copy of the slides, please visit the poisoning data page on our branch website, injuryfreenc.dhhs.gov. The direct link is also shared at the end of this presentation. Feel free to incorporate these slides into your own presentations, grant proposals, reports, or any other way they may be useful. Please read both the speaking and technical notes to ensure that data are presented in a consistent manner. Before we begin, I'd like to point out a few technical notes that will help with interpretation of the data. The majority of the fatality data presented here come from the Vital Registry System of the North Carolina State Center for Health Statistics. Historically, we have used the ICD-10 codes found in death certificates provided by the State Center, but we acknowledge that there are some challenges to the ICD-10 coding system. Therefore, we want to remind everyone that the definitive, most recent source of death data comes from the North Carolina Office of the Chief Medical Examiner, or OCME. OCME also has data on deaths involving specific drug types. Finally, because of a transition in the hospital and emergency department coding structure in October 2015 from ICD-9-CM to ICD-10-CM, there are now different definitions for injury, including poisoning hospitalizations and ED visits. This unfortunately means that data occurring after the transition cannot be compared to data occurring before the transition. For more detailed technical notes on any of the data shared in this slide set, please contact us at substanceusedata@dhhs.nc.gov. This presentation is not intended to cover all data related to the overdose epidemic. Rather, it gives an overview of some of the key trends in North Carolina. It includes information on statewide medication and drug overdoses, opioid-related overdoses, and our state's response coordination. The Injury and Violence Prevention Branch maintains a master slide set that also includes national data and more information on our state's response. Please contact us if this presentation does not contain the information you're looking for. County and regional level slides are available on the IVPB poisoning data page linked on this slide. First, we'll begin with statewide medication and drug overdose background and trends. Medication and drug overdose deaths consist of a broad category of medications, drugs, or biological substances, including prescription, over-the-counter, and illicit substances. Here are 50 years of data for two specific types of injuries. For most of the past century, motor vehicle deaths were the leading cause of injury death in North Carolina and the U.S. In North Carolina, poisonings from all intents overtook motor vehicle crashes in 2010 to become the leading cause of injury death. The decrease in motor vehicle incidents can be attributed to the implementation of seatbelt laws and several changes to safety measures in the construction of automobiles and roadways. The rise in poisoning deaths can be linked to a shift in focus to treating pain as the fifth vital sign, new formulations of opioids such as oxycodone, and increased marketing of pain medications to the public. Motor vehicle deaths continue to decline, but drug poisoning deaths continue to rise. These two lines tell a powerful story of public health and the society at large ability to address a significant health issue over time. With a combined approach similar to that used to reduce motor vehicle incidents, poisoning deaths can be prevented as well. In North Carolina, as in the United States as a whole, deaths due to medication-drug overdoses have been steadily increasing since 1999, and the vast majority, 92% of these, are unintentional. The number of medication-drug deaths has increased 120% over the last 10 years, 2010 to 2019. While the number of self-inflicted deaths have remained relatively stable at less than 200 a year, unintentional drug overdoses have continued to rise, though there was a decrease in deaths from 2017 to 2018. Opioids specifically have contributed to the majority of these deaths. In 2019, an average of 6 North Carolinians died each day from unintentional medication or drug overdose. Though largely driven by opioids, this number includes overdose deaths from other medications and drugs as well. For example, cocaine, benzodiazepines, and others. The highest rates of unintentional medication and drug overdose deaths occurred among North Carolina residents aged 25 to 54, males, and whites and American Indians. These rates are calculated over a 5-year time period, 2015 to 2019, in order to provide greater reliability. This map shades the counties of North Carolina based on their respective unintentional medication drug overdose death rate. The statewide rate of unintentional medication and drug overdose deaths was 18.5 per 100,000 persons from 2015 to 2019. This 5-year period was used in order to provide greater reliability in county-level rate estimates. In counties with fewer than 5 deaths, rates were not calculated. Please interpret rates with caution in counties with fewer than 10 deaths. The epidemic of medication drug overdose is mostly driven by opiates. Historically, prescription opioids like hydrocodone, oxycodone, and morphine have contributed to an increasing number of medication drug overdose deaths. In recent years, other synthetic narcotics like heroin, fentanyl, and fentanyl analogs have resulted in increased deaths, and while there was a decrease in the number of deaths involving heroin and other synthetic narcotics from 2017 to 2018, it increased again in 2019. The number of deaths involving other substances like cocaine, benzodiazepines, alcohol, antiepileptics, and psychostimulants with misuse potential, including methamphetamine, continue to rise. These counts are not mutually exclusive. If a death involved multiple drugs, it can be counted on multiple lines. A growing number of deaths involve multiple substances in combination. For a detailed description of what's included in each of these categories, please visit our webpage where we've developed a poisoning surveillance definitions table that you may find helpful. This slide looks at both the number and percentage change in unintentional medication and drug overdose deaths among North Carolina residents over the last decade. Under the number of deaths in each bar, you'll see the percent increase or decrease in parentheses compared to the previous year. From 2018 to 2019, North Carolina saw a 4% increase in the number of unintentional medication drug overdose deaths. This slide also shows counts and percent increase or decrease, but in the number of visits to the emergency department and hospitalizations related to unintentional medication and drug overdose. From 2018 to 2019, the number of unintentional medication and drug overdose ED visits and hospitalizations decreased by less than 1%. This slide contains data from the North Carolina Youth Risk Behavioral Survey, YRBS. YRBS is a representative sample of high school students in North Carolina. Self-reported survey data often gives an underestimate of drug use. In 2013 and 2015, students were asked if they'd ever taken a prescription drug without a prescription or differently than indicated by a doctor. This question included any type of prescription drug, such as OxyContin, Percocet, Vicodin, codeine, Adderall, Ritalin, or Xanax. In 2017, this question was changed to ask specifically about prescription pain medicines, such as codeine, Vicodin, OxyContin, hydrocodone, or Percocet. Let's take a closer look at overdoses involving opioids across the state. From 2015 to 2019, the statewide rate of unintentional opioid-related overdose deaths was 15.3 per 100,000 persons. Again, this 5-year period was used in order to provide greater reliability in county-level rate estimates. In counties with fewer than 5 deaths, rates were not calculated. Interpret rates with caution in counties with fewer than 10 deaths. This slide looks at number of unintentional opioid overdose deaths among North Carolina residents over the last decade and the percent change from the previous year. From 2018 to 2019, North Carolina saw a 5% increase in the number of unintentional opioid overdose deaths. Unintentional opioid overdose death rates for North Carolina residents have greatly increased from 2015 to 2019. This shift has been true for the state as a whole and also stands true when the data are stratified by primary designation as urban or rural. Statewide, the opioid overdose death rate has increased from 10.5 per 100,000 in 2015 to 17.2 in 2019, a 64% increase. Among urban counties, the opioid overdose death rate has increased from 9.5 per 100,000 in 2015 to 16.1 in 2019, a 69% increase. Among rural counties, the opioid overdose death rate has increased from 12.6 per 100,000 in 2015 to 19.5 in 2019, a 55% increase. With an unprecedented availability of cheap heroin and fentanyl, more people are dying. Heroin is twice as potent as morphine. Fentanyl is 100 times as potent as morphine. And carfentanil, a fentanyl analog, is 10,000 times as potent as morphine. Please note that the images in this figure are not to scale. This graph depicts the increase in unintentional opioid overdose deaths. Unintentional opioid overdose deaths have increased from 114 deaths in 1999 to 1,808 deaths in 2019. These numbers include deaths from both prescription and illicit opioids. The green lower portion of this graph shows the number of opioid deaths due to prescription opioids. The dark blue portion above shows the number of opioid deaths due to illicit opioids. The light blue middle portion of the graph are deaths due to both prescription and illicit opioids. Prescription opioid deaths have been slightly decreasing with the occasional small increase since 2008. Deaths due to illicit opioids have been increasing and are accounting for a larger proportion of the total unintentional opioid overdose deaths. Though there was a decrease from 2017 to 2018, in 2019 the number of deaths involving illicit opioids increased again. The concept of the injury pyramid is that deaths are only the smallest tip of a much larger burden on the healthcare system and the economy. In 2019, for every one opioid overdose death of any intent, there was over one hospitalization and 3 ED visits due to opioid overdose. The National Survey on Drug Use and Health estimates that over 326,000 people 12 and older in North Carolina misused prescription pain relievers in the last year, while the Controlled Substance Reporting System shows that over 6.2 million prescriptions for opioids were dispensed in 2019. Emergency department visits for opioid overdoses were steadily increasing from 2010 to 2017. The use of naloxone by emergency medical services has also increased dramatically during this time. However, in 2018, there was a decrease both in opioid overdose ED visits and naloxone administrations by EMS, and numbers decreased again slightly in 2017. Hepatitis C, or HCV, the most common blood-borne infection, is most often spread by sharing injection supplies. New HCV infections increased more than 395% over the last 10 years, from 2010 to 2019. The biggest increases in acute HCV are often in the same regions and the same demographic groups with the highest rates of overdose deaths. The number of heart valve infections, also known as endocarditis, associated with injection drug use have increased more than 4,000% since 2010. All of the data described above are part of a comprehensive approach to address the overdose epidemic. In the next several slides, we'll go over the response strategy, data from our partners that complement these efforts, and prevention measures. To combat the opioid crisis, the North Carolina Department of Health and Human Services worked with community partners to develop North Carolina's Opioid Action Plan, or NCOAP. The NCOAP launched in June of 2017, and the updated NCOAP 2.0 launched in June 2019. The plan sets key strategies that the state is focused on to reduce addiction and overdose deaths. The opioid data dashboard on this site is meant to provide integration and visualization of state and county level metrics for stakeholders across North Carolina to track progress towards reaching the goals outlined in NCOAP. For more information on the NCOAP, visit ncdhhs.gov/opioids. As part of the OAP 2.0 strategy to reduce the supply of inappropriate prescription and illicit opioids, North Carolina reports on the percent of unintentional opioid overdose deaths that involve illicit opioids. This map depicts these data for 2019. Statewide, illicit opioids were involved in 88% of unintentional opioid overdose deaths. Within the OAP 2.0 effort to prevent future opioid addiction by supporting children and families, we also monitor the number of hospitalizations due to drug withdrawal in newborns. Often referred to as neonatal abstinence syndrome, or NAS, this number has increased 154% from 2009 to 2018, 10 years. Since 2017, however, there have been decreases each year. This syndrome occurs when the fetus is exposed to certain drugs in the womb and then experiences withdrawal when the supply of drugs is severed following birth. Drug withdrawal in newborns is often, but not always, due to maternal use of opioids during pregnancy. However, drugs other than opioids can also result in withdrawals in newborns. NAS is not currently a reportable condition in North Carolina. In North Carolina, syringe service programs, or SSPs, were legalized in 2016. As part of the OAP 2.0 strategy to advance harm reduction, SSPs report data regarding their activities to the state on an annual basis. From 2016 to 2019, SSPs distributed over 113,000 naloxone kits. During this time, over 18,000 opioid overdose reversals were reported to SSPs. Fair chance hiring ordinances address the non-medical drivers of health strategy in OAP 2.0. These policies delay questions regarding a criminal record history until the interview process, when the applicant has had a chance to show their qualifications and explain their criminal history to the employer, after which employees may still conduct a background check. Exceptions for law enforcement or childcare-related jobs are normally made under fair chance hiring policies. Fair chance hiring policies have bipartisan support, giving all Americans a fair chance at employment, reducing the number of people who go to jail and prison, increasing the tax base, and ensuring a healthy economy. The OAP 2.0 strategy to address the needs of justice-involved populations includes providing access to medications for opioid use disorder in jail settings. Overdose is a leading cause of death among people recently released from correctional facilities. This risk is the highest during the first 2 weeks post-release. Providing access to MOUD in jail settings can reduce not only overdose risk, but also post-incarceration illicit opioid use, criminal behavior, and risk behaviors associated with infectious diseases like HIV or HCV. Additional social, medical, and economic benefits to providing MOUD to incarcerated persons with opioid use disorder are also well documented. As of the most recent report, in North Carolina, 11 counties provide at least one of the following 3 types of FDA-approved MOUD: methadone, buprenorphine, either on its own or combined with naloxone, and naltrexone. The implementation of SSPs is part of the Expand Treatment and Recovery Strategy of OAP 2.0. Counties shaded in blue were served by at least one as of the end of Year 3 annual reporting period in June 2020. Individuals traveled from an additional 38 counties and from out of state to reach a North Carolina SSP. There may be SSPs operating that are not represented on this map. In order to be counted as an official SSP, paperwork must be completed with the Division of Public Health. Additional SSPs may have started operating since the Year 3 annual reporting ended. For additional information on the NC Safer Syringe Initiative, visit ncdhhs.gov/divisions/DPH and select North Carolina Safer Syringe Initiative. The 7 strategies detailed above can be found outlined in this table and broken down into 14 key metrics and recommended actions being tracked as part of the NC OAP 2.0. As a recap, the 7 strategy areas are as follows: track progress and measure our impact, reduce the supply of inappropriate prescription and illicit opioids, prevent future opioid addiction by supporting children and families, advance harm reduction, address the non-medical drivers of health and eliminate stigma, address the needs of justice-involved populations, and expand access to treatment and recovery supports. Dashboard data are updated monthly whenever possible. Data are available on the dashboard for the state and at a county and regional level. The Injury and Violence Prevention Branch, IVPB, posts multiple resources, many of which are updated monthly, to the IVPB poisoning data page at injuryfreenc.ncdhhs.gov/datasurveillance/poisoning.htm. To join our listserv and receive email notification of new reports, please email us at substanceusedata@dhhs.nc.gov. This has been a presentation on North Carolina's 2019 overdose data. Thank you for joining us.